The drug Suboxone is often described as a breakthrough in addiction treatment, a humane alternative to punishment, a medical solution to a devastating problem. And in some ways, it is. But there's a question that rarely gets asked out loud. Is Suboxone actually treating addiction, or is it simply managing it? Because those are not the same thing. Hello, I am Dr. K. Paul Stoller, and I developed an addiction protocol that actually works, and you can learn about it at my website KENNETHSTOLLERMD.com. But I don't say too much about Suboxone in my webinar simply because it doesn't work. I didn't explain why it doesn't work in my webinar, but I will here because I think it is important for those addicted to opioids to understand why conventional addiction treatments don't work. At a pharmacological level, Suboxone does exactly what it was designed to do. It's a partial opioid agonist. That means it occupies opioid receptors strongly enough to prevent withdrawal and craving, but weakly enough to blunt euphoria and reduce overdose risk. In short, it keeps people from crashing. That matters. It saves the lives of addicts in the short term. But it also means something else. The person remains opioid dependent. The brain does not reset. Neuroadaptation remains. The underlying drivers of addiction are still there. Suboxone stabilizes. It does not restore. Clinical guidelines often describe Suboxone as a bridge, but it is a bridge to nowhere. A temporary intervention meant to help people stabilize before transitioning to deeper recovery work. But in real-world practice, that transition rarely happens. Many patients remain on Suboxone for years, sometimes for life. After about 2 years, patients are often told they should consider tapering or moving to another approach. But tapering is hard. Withdrawal can be prolonged. Psychological distress can be intense. Fear of relapse keeps both patients and clinicians locked in place. So instead of crossing the river, people tread water indefinitely, not actively addicted, but not truly recovered. This is where definitions matter. Suboxone performs reasonably well on the metrics that healthcare systems value: retention and treatment, reduced illicit opioid use, fewer overdoses. Those are important outcomes, but they quietly redefine success. Because what isn't measured often doesn't matter. We don't ask, has agency been restored? Has trauma been addressed? Has meaning returned? Does the person feel free? When survival and compliance become the primary endpoints, a palliative strategy can look like a solution. If Suboxone is, at best, a partial solution, why is it the dominant one? The answer likely greed and the structure of conventional medicine. Modern addiction medicine is overwhelmingly pharmaceutical-centric. Physicians are trained to prescribe. Insurers reimburse medications. Guidelines privilege FDA-approved drugs. Health systems scale what is standardized and billable. Suboxone fits perfectly. It's prescribable in an office visit. It's regulated. It's measurable. And for much of its history, it was highly profitable. What fits the system becomes the system. Many interventions that address the roots of addiction don't fit this model. Things like trauma-informed psychotherapy, long-term residential programs, community-based recovery, metabolic and nutritional interventions, neuroregulatory therapies, identity, and purpose-based rehabilitation. Some of these approaches show promise. Some are transformative for the right person, but they're harder to standardize, harder to scale, and harder to monetize. So they remain underfunded, underutilized, or simply unknown. What isn't profitable becomes invisible. Suboxone's dominance is also reinforced by how we define evidence. Clinical trials are designed to measure retention in treatment, reduced illicit opioid use, fewer overdoses. They rarely measure long-term autonomy, psychological integration, quality of meaning, restoration of self-trust. When the only outcomes that count are the ones easiest to measure, deeper recovery becomes optional. And optional things rarely survive institutional pressure. Taken together, this creates a system optimized not for healing, but for containment. Suboxone keeps people alive. It reduces chaos. It lowers immediate risk. Those are real achievements. But containment is not cure, and when a palliative tool becomes the default destination rather than a temporary support, expectations quietly collapse. We stop asking if people can be restored. We settle for keeping them functional. This is not an argument to abolish Suboxone. For some individuals, it is genuinely life-saving. But it must be understood honestly for what it is, a stabilizing intervention, not an endpoint. The ethical problem is not using a palliative tool. The ethical problem is allowing it to crowd out more comprehensive approaches simply because those approaches are less profitable, less scalable, or less convenient. Addiction is not just a chemical problem. It is a disorder of trauma, meaning, regulation, identity, community. No single pill can address all of that. If addiction medicine is to mature, it must expand beyond what pharmaceutical companies can offer. Otherwise, treatment will continue to reflect the limits of the system, not the full potential of human recovery, and many people will spend their lives treading water, mistaking survival for freedom. Addiction medicine is heavily pharmaceutical-driven. Treatments that are FDA-approved, billable, scalable dominate practice. Deeper, non-pharmaceutical or restorative interventions remain marginalized. And even naltrexone, which does make sense for alcohol use disorder, is still largely palliative, not curative, much like Suboxone is for opioids. I discuss this in some detail in my webinar course, The End of Addictions, at KENNETHSTOLLERMD.com, along with a protocol that does work.